Welcome to a special edition of the Impact Equation. We're delighted to be working with our friends at 100x Impact Accelerator on this new series, Scaling Tomorrow's Social Unicorns. Join us as we dive into a 4-part series featuring 6 trailblazing social entrepreneurs who are transforming their communities around the world. 100x is based at the London School of Economics, and applications are open for the next cohort this September. Find out more at 100ximpact.org. Today's guest is Neha Verma, co-founder and CEO of Intelehealth, a telemedicine technology non-profit that delivers health services where there is no doctor.
Intelehealth's approach uses telemedicine and artificial intelligence to bridge critical healthcare gaps in rural and remote regions, connecting patients with qualified healthcare professionals who wouldn't normally have access to high-quality healthcare services. Neha earned an MS in Applied Health Sciences and a PhD in Health Informatics from the Johns Hopkins University School of Medicine. Neha writes about women in tech, product development, organizational strategy, social impact, and non-profits too. Neha, a warm welcome.
It's great to be here. Thank you for having me.
So Neha, it would be great if you wouldn't mind taking us back to your personal story and what led you to a career in health and in impact.
I was always interested in the healthcare sector. I did my undergraduate degree in biomedical engineering, ending up by default. I was too young to know what I wanted to do, and I ended up in biomedical engineering and realized I really love healthcare. But why I started working in the impact sector really was from a deeply lived personal experience. After I studied biomedical engineering, I actually built and sold a startup. I was really young, didn't sell it for a lot of money, but it was good success to have, when you're 19, 20 years old. But then I found myself in an abusive marriage for a number of years, and it took a lot of effort for me to get out of it. And I experienced what it's like to have your agency curtailed, your health and reproductive rights curtailed. And Intelehealth, I like to say, was born out of my feminist rage to want to make a difference for women, to make sure that they didn't have to experience the same challenges I did. I really saw firsthand how much digital technology and digital spaces can be a safe space for women to overcome some of those barriers of patriarchy, of agency that really hold them back from accessing healthcare. And that's really what my work is about, not just at Intelehealth, but also in the work that I do in academia and writing. So that's how I ended up here.
Amazing. Thank you so much. And I'm really interested in who or what may have been your sort of greatest inspirations, perhaps people or mentors or books even that have really, really contributed to your path.
I think my first inspiration came when I was doing my undergrad, and I was working with a nonprofit to train women in urban busties or low-income communities on making paper bags out of donated newspapers from airline companies. And it was just, these women were so inspiring for me because they really wanted to make a difference for their own families. They wanted to pull their families out of generational poverty, and that their grit and determination was the first kind of seed of inspiration for me to do something in the impact sector. It was only later that I walked a mile in their shoes because I grew up with a lot of privilege. And that was one. And then when I came to Johns Hopkins, I met with some incredible mentors. I had the pleasure of working with Dr. Soumya Dutta Acharya and Dr. Alan Lebreek, Dr. Yusuf Yazdi. All of them really shaped my thinking on how technology can really bridge these gaps. They were all doing really incredible work in women's health and in improving access to healthcare through tech and AI. And so it was a pleasure to work with them. Great to do my PhD with them because I learned a lot.
And tell us about the startup that you founded. What was that and how did that come about? And where was that in your story in terms of, with your personal life?
Oh, I finished my undergrad. I graduated into the worst job market. And there really weren't jobs for biomedical engineers. And I was fortunate enough to be connected with this Brazilian doctor. My father is a dentist, and the Brazilian dentist that we worked with had a technology for smile design. So it was like an app that you could take pictures of your teeth, and then you could design a smile using the app, and then print it out and give it to the patient on a 3D printer, and then give it to the patient to try before they went in for face altering cosmetic surgery. So I worked with my dad to incorporate this business. We became the sole licensor and distributor of it in India. We built it up to, almost 60, 70 dental practices delivering this technology, made a good amount of money, also providing like the laboratory work to craft the teeth. And it was a lot of fun. And then our exclusive license ended and other competitors came into the market. It was also fun, but it was not fulfilling for me. So we sort of closed down the company, and then I went to school in the US. So that's a little bit about my first startup. We also built another product that used AI to predict your risk of cavities and build a plan so you could prevent it. And that failed miserably. And it taught me so much about what it means to build a successful business and a good product.
Why did it fail? What was the challenge? That sounds like a great idea. What led to that not working?
I think our go-to-market strategy, we were going to use dentists to distribute this technology to their patients. But dentists are not incentivized to keeping patients cavity-free. Also, I feel like market timing-wise, we were really off. This was back when AI wasn't as technologically strong as it is today. I mean, today we have large language models. We have all of these advancements in machine learning. So the cost for us to deliver AI solutions back then, they were very high. And those were not a price point that dentists or patients were willing to pay. There was not at all any acceptance of AI in the medical community or even generally in the population. It taught me market timing is everything. Like Facebook wasn't the first social media platform, but it was timed so well with the iPhone, and because of mobile computing, it came at a market time that was perfect. I feel like that ended up happening with Intelehealth as well, with a pandemic happening right in our early years, which really propelled us. So that's one thing I definitely learned. And then the second is, you could build a great product, but business model is everything. Do people actually want to use it? Are you really solving a pain point for them?
Yeah.
And that's why I went to school at Johns Hopkins to a program that actually, it was a program that had a curriculum that focused on entrepreneurship and all of these things around entrepreneurship. How do you build successful technology companies?
Neha, would you mind sharing with us a bit more about Intelehealth, just so we understand a bit more about what it is and what it does?
So Intelehealth is a nonprofit that supports public healthcare organizations, so mostly governments, to implement telemedicine into their existing brick and mortar healthcare systems. So we had turned these brick and mortar healthcare systems into brick and click healthcare systems. So if you're a large hospital group or a government that's providing healthcare services to the bottom of the economic pyramid, Intelehealth provides a really high quality open source AI enabled technology platform. And we also help these governments with the right workflows, training for their healthcare providers, implementation support, so that they can meaningfully implement telemedicine in a way that delivers real impact for low income patients and women.
So tell us from the perspective of those women, what are the challenges they're facing? What's the current situation before access to Intelehealth? Why is that? And then how does it feel for them to engage with the platform?
So we work mainly in rural areas and in areas of low-income areas. So most of these women don't have their own phones and they don't have a lot of agency. So 6 out of 10 women in rural India delay or forego seeking healthcare. When they have a health issue, they may go to a local community health worker or a nurse, and they're able to get care for some health issues, like maybe they're having a routine pregnancy checkup. That's something a nurse can handle. But if there's something wrong with that pregnancy, the nurse will refer them to the next level health center. Now, that next level health center is 20 kilometers away, would take the whole day, sometimes 2 days to go and come back. Women don't have the money to do so, the agency to do so. Most of them need permission or a companion to make that journey. And so they just forego seeking healthcare. They live with entirely preventable and treatable health issues. Now, what Intelehealth does is I work with governments to identify these nurses and nurse-run primary care clinics that the government operates, and we layer telemedicine on. So rather than the nurse referring that woman with the high-risk pregnancy, she can pull in a doctor. That doctor can have a video consult. The nurse is right there. The patient is right there. They can identify what's going wrong. That nurse can dispense medications, can invest in health education for that woman. And the woman leaves with a dignified healthcare experience. And what we've been able to see in places that implement telemedicine, 9 out of 10 women can get to the care they need in 8 hours. So that's really a transformative shift. And for me, the other part that feels great is that it really restores a sense of dignity. When you can take care of yourself on your own terms, it restores that sense of dignity to you. And so that's, aside from the fact that you're getting better, you're also able to get access to that basic human right.
And what's your route to market in terms of these people if they haven't got phones, haven't got digital access? Like, how are you reaching out to them? How are they aware of your service? And I suppose, how does that then help you to scale?
Yes, so that's why we work mainly in provider-to-provider telemedicine. So we connect these nurses to higher-level healthcare centers rather than working directly to patients. So how do these women find out about it? That's the second part of what we do. So aside from the software, we provide the government with a 6-step implementation process, which includes things like marketing. How could you use press and radio and media to make sure people know that these government health centers are now offering telemedicine? We work with community health workers or village leaders to allow for word of mouth publicity. What we find, though, is that after the first few patients get care from these nurses, it ends up really spreading by word of mouth, because these are small communities. It's 5,000, 3,000 to 5,000 people living in the area around these primary care clinics.
Neha, could you explain a bit more about the circumstances of living in rural parts of India? Because I think for many of our listeners, that might be an experience they have yet to have. So if you wouldn't mind sort of, I guess, sharing with us more about the circumstances, what they might be doing on a weekly basis, just so we can get more sort of into the experience of the rural areas.
Of course, it's hard to pick a typical rural area given, how diverse and large India is. But let me pick one which could kind of give you a sense of what it would be like. This is a site where we work in Maharashtra in a place called Nasik. The nearest city is 70 kilometers away, but it takes 4 hours to get there. When you reach the village, it's usually smaller homes. Think about yourself walking down that street. It's very beautiful. It's green. And you have homes that are spaced quite far apart. The common occupation is agriculture. Most of these are agrarian economies. And a household will have 6 to 8 people. And that household is living on an annual income of 500 to 1,000 US dollars. Let that sink in for a second. It's an amount of money we spend on a flight ticket, is what an entire family of 6 would spend for a whole year. And they mainly access services through the government, through public sector. So they go to public schools, public healthcare, and most of these communities are also very patriarchal. So women have lesser agency. Things are changing, of course, and like I said, it's not typical of all of India, but this could maybe give you a sense of what it's like. So if you need to access a healthcare service, you're looking at going to that nearest nurse-run primary care clinic that you can walk to, or if you can't be treated there, you're taking a bus or you're going by a bicycle to the nearest town or city.
In terms of government and politics in India, it's obviously a country now of over 1 billion people, very large states. And he talks about government being a key part of your delivery mechanism. But obviously engaging with local government and national government is perhaps different to how it is in the US or in the UK. Could you share us a bit of insight into how you go about engaging with government at a local and a national level?
I will say that the Indian government has had a very clear digital first agenda. So our first point is really finding those areas of overlap. What are the incentives? Why does government want to engage with us? when we started working with government, it was for the e-Sanjeevani program, which is India's national telemedicine system. It was rolled out during COVID. And we started working with the government literally bottom up. I don't have a lot of connections within the government sector. So we would literally go clinic to clinic, talk with nurses, village to village, talk with patients and ask them, do you know about this telemedicine service? What challenges do you face accessing it? And we made a report on all of those challenges. And then when we showed up at the more senior government official, first off, they'd already heard that there's a nonprofit that's been poking around and asking all of these questions around telemedicine and the challenges that people face. But when we were able to provide them with data and evidence around what the gaps are in the program and what we could do to fix that, what we could do to partner with the government to enhance the delivery of their systems, we found very willing partners. And when we started off, we partnered with the government of Jharkhand, which is a state towards the northeastern part of India. And we were working in 5 districts in Jharkhand. Pretty soon, when seeing the results we were able to demonstrate in those 5 districts, the state government actually asked us to work statewide.
Why did you choose Jharkhand in the first place?
It is one of the states which has some of the poorest development indicators when it comes to healthcare. It's a largely tribal state, and tribal rural communities, so indigenous rural communities, have some of the poorest healthcare indicators. So we definitely didn't choose the easiest place to work in. And it was also a place where Intelehealth had been working with local NGOs for a number of years. So we were very comfortable with that area. We knew the language, we had local knowledge and cultural competency.
So the sort of story of the organizations, you started out as a NGO, talking to NGOs, and then to scale, you started to speak to the sort of government actors, and now you're growing across India. Are you growing across other countries, or are you focusing on India?
Yes, we are. Actually, when we started off, we were setting up our own telemedicine clinics, like hiring nurses and health workers and setting up facilities. And we realized quickly that that's a very asset-heavy model, and that's not going to scale. So we still run those clinics today, but the model of scale was to, we have these sites, we've shown that it works. We invited NGOs to come and see our site. Some of these NGOs said, okay, we'd like to adopt your technology and implement it during COVID. And then from there, yes, like you mentioned, we went to government adoption. And yes, we are now working with other countries as well. We work with the Ministry of Health in Kyrgyzstan. So all in all, Intelehealth, since it started in 2016, has served 10 million patients.
Amazing.
Today, we work in 7% of all health facilities in India and 20% of all health facilities in Kyrgyzstan.
Just so happens that I've been to Kyrgyzstan, Neha. Not sure many people you've spoken to have. Amazing place, beautiful scenery. I've gone to some crazy scrapes there. I'd love to know, just sort of step back a sec, what is the product? Like when you're in the clinic or when you're installing the clinic with the government agency, what are you bringing to the NGO or to the space?
So the first thing we have is an open source technology platform. It's an app, a mobile app and a web app. So it's multi-channel. And it also has a helpline component to it. So a patient can get connected to a doctor via a local healthcare worker. They can also pick up the phone and speak with that local healthcare worker from their home. So you have these 2 ways, and then that health worker connects them to a doctor. The application is fire compliant. It works in very low bandwidth internet. So we've optimized video calling to work in 1 Mbps internet connection. So that's like a 2G to 3G network. So it really works in very low bandwidth. And then in places with even lesser bandwidth, you can do text or chat and audio only consults. That's a little bit about the software. So that's one thing we do. But what we find is that whenever a health organization wants to implement telemedicine, they first think, let me go procure a software. But ideally, what they should do is take a step back to understand what's the healthcare problem I am trying to solve. Am I trying to treat patients with diabetes and hypertension? Am I trying to provide primary care services? Maternal child health? Based on the problem that I'm trying to solve, the way I implement it would change. The features I need in the tech would change. So what we offer to nonprofits is a 6-step implementation process. So when you work with us, we provide the tech and this handbook, which has these 6 steps. Step 1, program design. sit down. We have if you've seen the business model canvas, the Osterwalder business model canvas, it's kind of similar to that, but it's called the telemedicine program design canvas. So you sit down and really get into what's the problem you're trying to solve? How are you going to solve it? What tech do you need? What would be your pricing model? What would be your costs and revenues? All of that. The second step is training all of your healthcare workers to use telemedicine. The third would be demand generation. How should we drive uptake of these services from citizens, from patients? The fourth step is quality assurance. How do we make sure every consult is of high quality? So what kind of quality monitoring and audits would you do in there? The fifth step is monitoring and evaluation. What are the impact metrics you want to track? You want to see improvement in HbA1c levels, improvement in blood pressure. And then the last step is capacity building. We don't want to be working with the government forever or with that nonprofit forever. So because we have kind of templatized or franchised our approach, the nonprofit or the government can continue to run the program, and we happily exit and move on to the next place.
Amazing. One other sort of explanatory question. How does it fit in terms of the sort of healthcare value chain? So, you're offering the diagnosis or your response, and then the handoff to the, on the ground delivery. How does it, surely that works differently in different areas. How do you help the sort of local, delivery partners to be part of the system that you're operating in?
That's exactly where brick and click comes in. We don't think virtual care exists in a vacuum. It has to be meaningfully integrated into that brick level. So in the program design, we work with the nonprofit or the government to understand things like, how will this connect with pharmacies? How would someone get medication after the consult? How would this connect to diagnostic labs? So if they need to do more diagnostic testing before they can get a diagnosis, where would they go? If they needed a referral for surgery, how would that work? If they needed access to insurance for that surgery, how would they get connected with the insurance system? So all of that gets covered in the program design. So we could create these brick and click workflows, and then you can customize the software and configure the software to make it adapted to the workflow of your organization and your context, because healthcare workflows really vary a lot from country to country, region to region, and even just two hospitals right next to each other would use very different workflows to provide healthcare services.
What an amazing, service that you're providing, and it's so scalable in terms of how you're delivering it. Like, it's adaptable to different contexts. What is your dream? Like, how are you going to take this model and scale it, beyond India and Kurdistan, take it global? What does that look like? What's the ambition? How are you going to get there?
So, yeah, we've impacted 10 million people to date, and that's very humbling and fulfilling. We want to 100x our impact and reach 100 million people in the next 5 years. That's a bold and ambitious vision, and we think we can get there by partnering with more governments, more subnational and national scale telemedicine programs. I definitely feel telemedicine is it's a ubiquitous part of the healthcare system now. Every health system should have it. You and I access care virtually, and it makes health systems more gender sensitive and more accessible. So to get to 100 million people, we want to partner with more governments. Very recently, we partnered with the World Health Organization to launch a series of webinars that train Ministry of Health leaders, hospital leaders in telemedicine. So we're really excited for that. All of these are ways in which we feel we would be able to achieve our dream and our reach.
And Neha, you mentioned 100xing your impact, and I noted that you're a portfolio company of 100x Accelerator. Could you share with us the kind of contribution that has made to you personally and also to Intelehealth?
About more than a year ago, when we applied to 100x, we were figuring out what scalability looks like or what our end game might be. We were trying a lot of things. And 100x was a huge part of helping us make our model such that we could reach that kind of a goal. It helped us think big, dream big, and then we had a lot of access to mentors from LSE and from other partners to find ways to make that practical, to find realistic and ways to make that. So it's not just a theoretical 100x or 100 million people number, but there's a credible pathway for us to get from where we are to where we want to be. And I think 100x was a big part of that journey. It was wonderful to be a part of the accelerator.
Fantastic. So tell us a bit more detail on that pathway. So you want to partner with more governments. How do you've got links with WHO. What are the barriers to doing that? What are you worrying about in terms of trying to deliver on that journey? Where do you expect it to go?
One of the barriers is policy. Many countries don't have a legal law that legalizes telemedicine. And if there isn't one in place, it's very hard for us to work there. That's one of the barriers. Another barrier, of course, is financing. Most of the countries where we want to work, low and middle income countries, they have very low GDP spends on healthcare and very low spends on digital health. And they're really reliant on multilateral and bilateral aid, specifically from UN agencies, from the WHO, from the World Bank or USAID. And there have been some shifts lately in that in the US with the new administration taking over, and that's expected to make a profound impact on countries' development journeys, especially those that are reliant on that kind of foreign aid. So aside from the regulation and financing, there are a few other challenges, of course, as well. Internet connectivity and internet penetration really needs to improve. And then in some places, we work in very sensitive areas that might experience climate disasters, natural disasters, and all of that kind of impacts the work because it disrupts the work that we do on the ground. So, we have a project in Syria, for example, that's currently, experiencing a lot of these challenges. So those are all kind of, some of the challenges that we experience when we scale.
Tracking back a moment to this sort of personal stories, because often, obviously, impacting on 10 million people is extraordinary. But there might be some sort of individual cases of interventions or health outcomes that you're most proud of. Would you mind sharing some of those with us?
We publish these very regularly on our social media. We have video testimonials and written testimonials of patients. There was very recently a story of a woman from rural Jharkhand who was experiencing a urinary tract infection. She didn't know she was experiencing that. So she was a day laborer. She lived in the fields. She did not have a permanent home and did not have access to a toilet, which resulted in her having this. And it was becoming very serious. She'd been living for almost 2 or 3 months with that infection. And she found out about this telemedicine program near her. She showed up at a healthcare facility. The nurse did a consult with a doctor because the infection had become extremely serious. It wasn't something as simple that the nurse was very confident treating with antibiotics. And the doctor was able to get her on the right antibiotic regimen, a regular follow-up program. And that woman left with medications and then came back later with just this smile on her face because she'd been living in so much pain and poor quality of life. And all it took was some medication to set her on the right pathway.
The things that we take for granted.
I know. Yeah.
And then in that example, it was the nurse who was contacting the doctor through telemedicine. So effectively, you're utilizing existing capacity, but connecting the patient and the nurse with the doctor in another jurisdiction.
That's correct.
Amazing. And can I just check, one of the things we spoke about before was how the state had seen the impact of the telemedicine or the solutions you put in place and wanted to scale it up across the state. What was it that they were seeing that gave them so much encouragement and wanted to expand the project?
Well, the first and foremost, the state of Jharkhand was doing 40 teleconsults a month before we started working there. Once we started working there, that jumped to 55,000 teleconsults a month. So just that dramatic increase in adoption was one. The second was provider acceptance. So because of the training that we were providing, the healthcare workers were able to understand when to use telemedicine, when not to use it, what are the limitations and risks associated with it. So you see this improvement in provider satisfaction. There were challenges like patients were not able, even though a nurse would start a consult, there wasn't a doctor on the other end to receive it. Or if a doctor would log in, there's no nurse requesting for a consult. So it's a multi-sided market model that you have to optimize. So because we did that, we started to see the system functioning more smoothly. And then, of course, there was very high levels of client satisfaction. We were able to show with each consult, you save 21 kilometers of travel and $11 in costs for the patient and $19 in costs for the health system. And all of those metrics were really what motivated the government to push this in other places as well.
Presumably also people that are able to, for example, the example of that woman who was on the wrong antibiotics but worked in agriculture, she was able to get back to work, to be able to be more productive. So is there a productivity kind of like a revenue side of things that the state or the national government look at as well? Or is it cost savings?
And maybe also a data one as well. Presumably you're able to more accurately and at a greater scale capture information on diseases and challenges that other parts of the healthcare system in these countries might find difficult to capture.
Absolutely. And we recently worked as part of a UN interagency task force that showed that if governments were to implement telemedicine, it would result in 199 billion in economic gains. Wow. Because of early diagnosis, early intervention, improved productivity, reduced costs for healthcare systems.
So in terms of like the way you want to take this next, where's like your dream country that you want to sort of grow into? Where needs this most?
We focus mainly on countries that have geographic health access gaps. So very mountainous countries like Kyrgyzstan, for example, or island countries like Indonesia. We're focused on Nepal, Indonesia, Kenya. These are just some of the countries that we're really looking to expand in the future.
Neha, as a social entrepreneur, there'll be a lot of lessons perhaps you've gained through your trials and tribulations building this organization. For social entrepreneurs starting out or growing their organizations, are there any sort of top tips or reflections that you'd like to share with them?
Oh my God. So many things. How do I pick the top ones? Let's see. Patience. It takes a long time and a lot longer than you thought it would to make real change and impact. And the second would be surrounding yourself with the right team is very crucial. And hiring people and bringing on and getting the right people around you for the next phase of your growth. So hire for who you need tomorrow, not who you need today. That was another thing that really was a big learning experience for me, because I think I would hire too much for the now and ended up always finding it hard to scale, and it would be very stressful to scale. Focus on evidence and impact, like validating your impact through studies. So partnering with academic institutions or professors, making sure you're measuring and quantifying the impact of your intervention as very early on is crucial. Other top tips, scale and sustainability are very overused words in our sector. Not everything is going to scale and not everything is going to sustain, and that's okay. And if you've come up with an intervention that is scalable and sustainable, that's wonderful. Power to you. I hope you will, apply to and go through programs like 100X. But if you don't have something that's scalable or sustainable and you're a nonprofit that's providing impact deeply in one community, that's okay too. There should be no, there's no comparison between depth of impact and scale of impact. Because the thing that happens when you scale impact is that you do compromise on depth. So that was another learning experience for me, because the kind of joy I get going to the projects where we set up our own clinics and service patients ourselves, there's so much deep impact, but it's not scalable. The costs are very high. And then when we work with government, we don't see the same depth, but we see scale.
Why is this depth not scalable? What's the reason for that?
When you scale, you always scale. One of the best ways to scale is via partners. And that's how a lot of nonprofits and impact organizations are scaling today. there's a really nice framework from the Mulago Foundation called Design for Impact at Scale, where you think about like your doer at scale and your payer at scale. When you're going to scale this, who's going to do the work? You're not going to be able to set up a clinic in every single village in every single country. And so you have to work with partners. And when you do that, it somewhere modulates the end impact of your intervention. Now, from a kind of net impact value, you probably are still doing more good in the world. You may be going an inch deep, mile wide, whereas in these deeper interventions, you're going mile deep, but inch wide.
I suppose the reason why I ask it is because for telehealth, it feels like maybe that equation isn't as difficult as it might be for other impact models, right? The depth that you're able to provide is it is inherently scalable because it's on the software. Right?
I wish technology and software solved all of our social impact problems.
Right.
But if we were to just provide the software to a new country, I guarantee you it's not going to create impact. To make sure that the technology actually results in impact, we have to provide all of these other things around behavior change, to drive behavior change, drive patients to adopt technology, drive providers to adopt technology, ensure that the care that's provided via the technology is of high quality. And that's a continuous investment. That human capital is a continuous investment into impact. So I wish that it was as simple as that, but in my experience, it has not been so.
Okay. I think that's a really important challenge to our audience, the people listening. You know, we're all about, on this podcast, we're all about change at scale. We're all about finding ways to, the impact equation for making the world a better place. And that means thinking about scale. But when you're doing that, as you say, there's always going to be challenges, going to be compromises you have to make. And how do we bring the pieces of the puzzle together to be able to do things that are big, but also with the quality and depth that are needed? And I think what you've told us today, Neha, is just the most incredible story of both of those things. You've led with the depth. You started out with those clinics. You've grown it through scale. You're taking it around the world as an amazing, scalable model. And maybe the next iteration for your organization is, once you've settled in these new areas, to then drop down into the depth as you have done at the beginning. Well, Neha, it's been a fantastic conversation. I've learned so much from it. I'm really inspired by what you're doing. I think it's the most amazing story and the most, hugely impactful work from an incredible, obviously, I don't know how old you are, but pretty young, really, really exciting, really, committed, authentic person. So, all power to you, and thank you for talking to us.
Thank you so much, Neha.
Thank you so much for having me and for putting this platform to just share our story and my story and these experiences within telehealth. So I really appreciate it. It's been great today. Thank you.
Well, Rafi, what a fantastic conversation. What do you take from that?
I loved it. What an incredible story. It's not an area that I'm so familiar with. I think, I'd love to hear your reflections as someone that's worked, social entrepreneur in health. But it feels to me like telehealth is one of those obvious sort of products, or one of those obvious things that really needs to scale and needs to operate globally and can solve such obvious problems in such a quick and highly effective and efficient way. And the fact that she's been able to build this huge, the incredible, impactful scale organization coming out of university, having done this 1-year program at Johns Hopkins, and now building this international powerhouse with a bit of help from 100X. What an inspiring person. So I'm so pleased that we had the opportunity to chat to her. I feel like, we didn't talk more broadly about telehealth and the sort of market space of telehealth, but presumably there's lots and lots of these kinds of organizations out there. The fact that she's so impact driven, though, means that I think this is a real chance of being a real game changer, system changer.
100%. I mean, 10 million people they'd engage with. I guess it's a large number of people. And again, her vision of getting to over 100 million, I mean, I wouldn't be betting against her to achieve that for sure. The things that came through for me, which I think the lessons to take away, were around how effectively she's engaged with local governments, how she built partnerships with NGOs and other delivery partners, I think is pretty extraordinary. And I think that what that does is help to think about the delivery models, because I suspect that her business model and their delivery model has changed as they've learned more and more on the ground.
Yeah.
And then, as she said, making sure the evidence comes through is critical. The more evidence you can demonstrate, the more you can validate, the more likely it is you're going to persuade buyers to continue to purchase and then scale those solutions, those interventions.
That makes sense. So it's kind of evolved, isn't it? There was like an initial sort of on the ground product proving itself, and then they've taken and sort of genericized that product in a way that can be scalable and genericized the partnership working with government and turned it into a framework that can then, go around different states in India and then now different countries. That approach to genericizing something, I think, is what enables scale. One thing we didn't talk about with her too much is about the funding model, which I'd be keen to follow up with her about, like, how do they find new funders to enable that scale alongside the governments would be an interesting conversation for next time. Reflecting on your experience, Adam, how did you find, doing something kind of similar in the care space, trying to take a digital product that would enable scale? Like, how did you see the overlap with what she's doing?
So in my experience, the business that I built with my brother was a direct-to-consumer business, and it was also a marketplace business. And both those have incredibly challenging dynamics, very capital intensive. You have to build a very strong consumer-facing brand. And again, it's sometimes a very high volume, high transaction to make it work economically. What she was sharing was that rather than going direct-to-consumer, they went to almost B2B2C. And I think in healthcare, particularly technology in healthcare, B2B2C models work really nicely. In other words, working with NGOs and frontline clinicians to provide a service at point of need with the patient. So the patient isn't the customer, but the patient is the user of the product alongside the nurse. And so that, I think, is a really compelling business model because it really enables the scaling of that software. If she was delivering that service fully integrated directly to consumers on the ground, again, far more capital would be required. In many ways, very, very, very complex. But she's both using their existing models, she's utilizing existing capacity in a really, really smart way. So in many respects, I think it's a really smart way of taking a challenging intervention and making it work. And as we heard, was it 40 telehealth consultations to 55,000 a month? Did I hear that correctly? In one state?
In one state, yeah, that's right, yeah.
And that's exactly what I mean. That's exactly how we managed it.
The other thing that I think is comparable with your story is that you built super carers on the back of your own personal experience of lack of care for your grandparents. And, for Neha, she had this, personal experience of being prevented from access to healthcare, and she wanted to open up through digital channels to people that have that lack of access. And I think having that personal story, that personal drive, it just makes it so compelling. And
makes a big difference.
Yeah. All right, Adam. Well, great to chat. Thanks to Neha and to 100X. And next time on Impact Equation.
Okay, next time.